Hi everyone. Today we are going to see about the face and brow presentation. See in this picture shows the face presentation and this shows the brow presentation. Malpresentation refers to a fetal presenting part other than the vertex. If it is breech or if it is shoulder, all those things are coming under the malpresentation. Fetal malposition refers to a position other than the occipito-anterior position. For example, if it is occipito-posterior position or if it is lateral position, all those things are coming under the malposition. Face presentation occurs when the attitude of the head is one of complete extension. That is, the occiput of the fetus will be in contact with its spine. Due to the extension, it will go backward and it will come in contact with the spine, and the face becomes the presenting part. And there will be complete flexion of the limbs with extension of the spine, and here the denominator is MENTO. That is, as usual, as like other baby, the limbs will be flexed towards the body, but only the head will be extended and it will be towards the occiput will be towards the spine. And in the case of face presentation, the denominator is MENTO. Next is the incidence of face presentation. Its frequency is about 1 in 500 births, and face presentation can be of two types: secondary face presentation and primary face presentation. Primary face presentation means if the presentation is face during the pregnancy itself. During pregnancy itself, if face presentation is there, means that is known as the primary face presentation. And if the face presentation develops during the process of labor, that is known as a secondary face presentation. This face presentation is more common in the case of multipara mothers. Next we can see about the etiology or causes of the face presentation. It can be divided into maternal causes and fetal causes. The maternal causes includes lateral obliquity of the uterus. That is, in case of multiparous woman, excessive laxity of the abdominal muscles and uterine muscles will be there. So when the uterus is getting contracted, actually the force of contraction will be acting through the fetal pole, and through the spine it will be directed towards the occiput. But here, because of the inefficiency of the uterine muscles, instead of acting over the occiput, it will be going over the chin, or it will be applying towards the chin, and that leads to the extension of the head. And next is contracted pelvis. In a flat pelvis, the head enters in the transverse diameter of the brim, and the parietal eminence may be held up in the obstetrical conjugate, and the head becomes extended and face presentation occurs. That is, in the case of contracted pelvis, we know contracted pelvis means if any of the diameter of the pelvis, any of the diameters of the pelvis is 0.5 centimeter less than that of normal, that pelvis is called as contracted pelvis. Already we know that in the longitudinal diameter, the obstetrical conjugate is the lesser diameter, and if already it is lesser, and in contracted pelvis again it will be less when compared with the other diameters. So if the head is entering into the obstetrical conjugate, because of the lesser size of the pelvis, it may get caught over there, and when it is getting captured over there, again and again when the uterus is contracting, instead of going downward or instead of descending downward, it may get deflexed. If the head is in the posterior position, vertex presenting remains deflexed. The parietal eminence will be caught in sacrocochlear dimension. Occiput does not descend and the head becomes extended and face presentation results. In the same way, if the head is entering in the posterior position towards the back, most probably the entering diameter will be sacrocochlear diameter. Sacrocochlear diameter means we know that it is the distance from the sacral promontory to the iliopectineal eminence. This diameter is also less, and if the fetal head is entering into this less diameter, there also the descent will be difficult because the diameter is less. So what will happen when the descent is difficult? Again and again when the pressure is getting applied through the spine, there is a chance for extension of the face, and that results in the face presentation. Next one, polyhydramnios. If the vertex is presenting and the membranes rupture spontaneously, resulting in rush of fluid, and that cause the head to extend as it sinks into the lower uterine segment. See, in the case of polyhydramnios, because of the excessive amount of amniotic fluid, more intrauterine pressure will be there. And in that case, when the membranes are rupturing from that high concentration with much force, the fluid will be coming out. So with that force, when the fluid is coming out, due to that force, the head may get extended, and that leads to the face presentation. Next one is fetal causes. The fetal causes include congenital malformations of the, or congenital abnormalities of the fetus, like anencephaly, that is small head, then congenital goiter. So in the case of congenital goiter, due to that growth in the anterior portion, it will be difficult for the baby to flex the head towards the chest. And the next cause is twist of cord, several round of cords around the neck. In the case of cord around neck, if several turns are there around the neck, that leads to the deflection, or that will prevent the proper flexion of the head. And next one is increased tone of the extensor group of neck muscles. If the neck muscles are having more increased tone, that may lead to the extension. And the next one is prematurity of the baby and intrauterine death. In these cases, in these two cases, the capacity of the muscles will be less, flaccid muscles will be there for the baby, and that leads to the extension of the baby. That leads to the extended attitude of the baby. And next one is multiple pregnancy. In the case of multiple pregnancy, if one baby is in the normal position also, sometimes the other baby may come to a different position. Otherwise, if two babies are in the normal cephalic presentation also, when one baby is occupying the space inside the pelvis, the other baby may not be having space to enter. So when the uterus is applying pressure, when the uterus is contracting, when the pressure is getting applied over there, there is no space for it to descend. So what will happen? When again and again, when you are applying pressure, it may get extended. And next we can see the different positions. First one is right mento posterior. That is, if the mentum, that is a denominator, if it is pointing towards the right sacroiliac joint, that position is known as right mento posterior. If the mentum is pointing towards the left sacroiliac joint, that is known as the left mento posterior. And if the mentum is pointing towards the right iliopectineal eminence, that is right mentolateral position. If the mentum is pointing towards the left iliopectineal eminence, it is left mentolateral. If the mentum is pointing towards the left iliopectineal line, it is known as left mentolateral. If the mentum is pointing towards the right iliopectineal eminence, it is right mento-anterior. If the mentum is pointing towards the left iliopectineal eminence, it is left mento-anterior. It is left mento-anterior, and this is left mento-posterior. Left mento-posterior. See, the mentum is pointing towards the left sacroiliac joint. Here the mentum is pointing towards the left iliopectineal eminence. Next one is mechanism of labor in the mento-anterior position. That is left mento-anterior position we are going to deal over here. Here the lie is longitudinal. Attitude is one of extension of the head and back. Attitude is extension. Presentation is face. Position is left mento-anterior. Denominator is mentum. Presenting part is left malar bone. Presenting part is left malar bone. Now let us see the cardinal movements or the positional movements. In that, first one is engagement. The diameter of the engagement is oblique diameter. That is, in the case of left mento-anterior, it enters into the right oblique diameter of the pelvis, and in the case of right mento-anterior, it enters into the left oblique diameter of the pelvis. And the glabella will be, mentum will be pointing towards the iliopectineal eminence. In the case of LMA, it is pointing towards the left iliopectineal eminence. RMA, it is pointing towards the right iliopectineal eminence. And glabella will be to the opposite sacroiliac joint. And the engaging diameter is suboccipitobregmatic 9.5 cm if the head is fully extended. If it is fully extended, it is suboccipitobregmatic 9.5 cm. And if it is partially extended, it is submendovertical 11.5 cm. If it is partially extended, submendovertical 11.5 cm. And next one is descent. Descent, we know that descent takes place throughout the labor. Here the descent will be happening with increasing extension, and finally the chin will comes and touches the pelvic floor. And the next movement is internal rotation of the head. We know that as per the second principle, whatever part comes and meets the resistance of the pelvic floor will rotate forward until it comes under the symphysis pubis. So here, when the chin comes and meets the resistance of the pelvic floor, it will rotate 1/8 of the circle until the mentum is coming behind the symphysis pubis. And finally, the chin will come under the symphysis pubis or escape under the symphysis pubis. Next one is flexion. This takes place at the centiput, vertex and occiput sweeps the perineum. The head is born. The diameter distancing the vulval outlet is submendovertical 11.5 cm. Submendovertical 11.5 cm will pass. Next is restitution. This occurs when the chin turns 1/8 of the circle opposite to the direction of the internal rotation. That is, the twisting movement that has occurred during the internal rotation of the head will be corrected by an untwisting movement. The next movement is internal rotation of the shoulder. Now this time the shoulder will comes and meets the resistance of the pelvic floor. So the shoulder also will rotate 1/8 of the circle. In the case of left mento anterior, the shoulder enter in the left oblique diameter of the pelvis and it rotate 1/8 of the circle and it will come to the anterior posterior diameter of the pelvis. And in the case of RMA, it will be just entering in the right oblique diameter of the pelvis. And next is external rotation of the head. This occurs simultaneously at the same time of internal rotation of the shoulder, external rotation of the head will occur. So the chin moves further 1/8 of the circle to the same side of the restitution, towards the same side of restitution. Next is lateral flexion. The anterior shoulder escapes under the symphysis pubis. The posterior shoulder sweeps the perineum and the body is borne by a movement of lateral flexion. Body will be borne by a movement of lateral flexion. So that's all about the mechanism of face presentation. The complete video of this mechanism I will be uploading in the next video. Next is diagnosis of face presentation. Diagnosis can be done by abdominal examination, ultrasonography and by the vaginal examination. When you are performing the vaginal examination, if you are able to palpate mouth, molar bone, and if it is forming a triangle and anus and ischial tuberosity is forming a straight line, that is known as Beck's sign. It's an indication of the face presentation. And usually when you are doing the vaginal examination, sometimes if it is a face presentation, the mouth you may mistaken it as anus and you may think that it is a breech presentation or buttocks presentation. But in the case of face presentation, if you're just keeping the fingers over that, you will feel, if it is mouth, you can feel the sucking effect. And second thing, if it is anus, surely your hands will get stained because of meconium. But if it is mouth, absence of meconium staining will be there. And on the abdominal examination, in the inspection, because of the S-shaped spine, there is no visible bulging of the flanks. And in the case of lateral palpation, in the MENTO anterior position, the fetal limbs are felt anteriorly towards the midline, and back is on the flank and it is difficult to palpate. It will be towards the flank, towards the back of the mother's body. So it will be difficult to palpate. The chest is thrown anteriorly against the uterine wall and is often mistaken as back. In the case of MENTO posterior position, back is felt to the front and will be easy for you to palpate it. Towards the podalic pole, it will be easy for you to palpate it because of the extension of the spine. In the pelvic dip, the head seems big and it is not engaged. The cephalic prominence is to the side towards which back lies. A groove between the head and neck is not so prominent. Here in the posterior position, the groove between the head and neck will be prominent. And in the auscultation, FHS is distinctly audible anteriorly through the chest wall of the fetus towards the side of the limbs. And in the case of posterior position, FHS is not distinct and is audible on the flank towards the sides of the limbs. Next is clinical course or outcomes. There is a chance for prolonged labor and it is due to the ill-fitting presenting part. If the presenting part is a well-fitted presenting part, it will act directly on the cervix and that leads to the proper dilatation of the cervix. But here the presenting part is an ill-fitting presenting part, so there is a chance for slow dilatation of the cervix, and when the cervix is dilating slowly, the duration of labor will get prolonged. And another one, when the duration of labor is getting prolonged, finally what will happen when the uterus is contracting and relaxing for a long period, the uterine muscles will go to a stage of inertia. So the effective uterine contractions will not occur. So that also may leads to the further prolongation of the labor process. And formation of elongated bag of membranes. I told you that face is not a well-fitted presenting part. So through the sides of the presenting part, this amniotic fluid will come and it will get stagnated in front of the presenting part. So it will form a bulging of the bag of membranes. And poor molding of the facial bones. We know that the skull bones will not get ossified fully during the process of labor. So the molding of the skull bones are possible during the time of labor. So if the presenting diameter is a little more, during the molding it will decrease and easily the baby will pass through the pelvis. But here the facial bones will get ossified during the process of before the process of labor itself. So the molding of the facial bones will not occur. So if the molding is not occurring, if the presenting diameter is more, it will be same, it will continue as same. So the delay of the rotation will occur. So there is a chance for even arrest of the labor also. And delayed engagement. If the presenting part is a bigger diameter, occipitofrontal or mentovertical, in that cases engagement may become late, or sometimes engagement may not even occur. And late internal rotation. Here also the reason is same. Due to the largest diameter, presenting diameter, the rotation may take time. And arrest at times insuperable obstruction if MENTO posterior fails to rotate anteriorly. This already I had told you. If the presenting diameter is more, there is a chance for arrest of the labor and there is a chance for malrotation also. Next is cord prolapse. I have already told you that the presenting part is, the face is an ill-fitting presenting part. So when the uterus is getting contracted, the umbilical cord may escape through the sides of the presenting part, through the sides of the face. So that may lead to the cord prolapse. And next is maternal trauma. If the presenting diameter is a largest diameter, for example, if it is mentovertical 13.5 centimeter, when this 13.5 centimeter is passing through the vagina, there is a chance for tear of the soft tissues of the perineum. And next one is postpartum hemorrhage. Already we have seen that there is a chance for prolonged labor, and due to the prolonged labor I have told you that there is a chance for uterine inertia, or there is a chance for weak contractions of the uterus. And if the uterus is not getting contracted effectively in the postnatal period, there is a chance for bleeding or postpartum hemorrhage. And prognosis, the maternal prognosis include In the case of MENTO anterior, maternal risk is not much increased. If it is an anterior position, the risk is less. But if it is an occipito-posterior position, there is a chance for arrest of the labor, or that is, the phase may get impacted. And in some cases, it can be manipulated too. That is, even if it is an posterior position also, by applying bimanual pressure under the guidance of ultrasound, you can bring it to the anterior occipito anterior position, and if you are able to bring it to the occipito anterior position, the outcome will be successful. And the fetal prognosis include, there is a chance for fetal bruising. See, if the face is a presenting part, when you are doing the vaginal examination, sometimes your fingers may damage the soft tissues of the face, and even your fingers may produce damage to the eyes, fetal eyes also. And there is a chance for cerebral hemorrhage and intrauterine hypoxia. When the duration of labor is getting increased, there is a chance for uterine hypoxia for the baby. And if the presenting diameter is a large diameter, when it is passing through the pelvis, there is a chance for compression, and that leads to the cerebral hemorrhage. And chance for increased operative delivery. So usually if the head is not rotating, or if there is a delay, and if fetal hypoxia is occurring, usually we will go for the operative delivery. And chance for infection. There is a chance for bacterial contamination due to the bacterial contamination from the vagina. And even when you are doing the vaginal examination also, your hands may introduce infection directly to the baby. And the baby may get laryngeal edema during the first 24 to 48 hours after the delivery. Next, let us see the management of labor in the case of face presentation. First, we should maintain strict asepsis. Already I have told you that there is a chance for infection. And next, vaginal examination. When you are doing the vaginal examination, you have to be careful, because already we have seen that there is a chance for causing injury to the eyes, and there is a chance for introducing infection. So because of these reasons, you have to be conscious. And bowel and bladder care. You have to empty the bladder and bowel, and that may lead to the easier passage of the baby. And diet. See, when the duration of labor is getting prolonged, the mother may get exhausted, so you have to meet the nutritional needs of the mother. Next is relief of pain. Already I have told you that here there's a chance for increased duration of labor. So throughout that process, the mother is supposed to bear that pain. So you have to give her adequate analgesics. And you should monitor the progress of the labor. If there is an arrest, or if there is any unexpected reaction, if fetal hypoxia is there, or if there is no progress in labor, or if the uterine inertia is there, signs of fetal distress is there, in that cases, you have to take immediate action. Next is rest and ambulation. During the process, you have to give proper rest to the lady. At the same time, you have to ambulate the mother also. And if there is any deviation from the normal, if signs of fetal distress or if any maternal unexpected reactions are there, immediately you have to inform the doctor. And routine observations of the fetal conditions and maternal condition also should be done. That is your routinely you have to assess the progress of the labor. You are supposed to check the vital signs of the mother. You are supposed to check the fetal heart rate. You are supposed to check the number of contractions, the progress of labor, everything. And fetal scalp electrode usually we won't apply, and in case if you are applying, you have to be careful and you should not injure the eyes. And overall assessment is to be done, and whenever you are doing the assessment, you have to record it. And you should see the pelvis for the adequacy. You should assess the size of the pelvis, and you should assess the size of the baby, and you should assess the associated complicating factors. For example, if teen pregnancy is there, gestational diabetes is there, eclampsia is there, pre-eclampsia is there, those conditions also you have to see. In uncomplicated cases, a wait and watch policy can be taken. Sometimes, in the case of face presentation, when the uterus is contracting, sometimes there is a chance for, again there is a chance for flexion of the head, and if it is getting flexed, that may lead to a vertex presentation, or sometimes there is a chance for further extension, and if it is getting extended further, fully if it is extended, the less diameter submentobrachmatic may enter, so there is a chance for normal delivery. So in that cases, you can just wait for a wait and watch policy. Immediately after the rupture of the membrane, if the membranes are rupturing during the process of labor, immediately after the rupture of the membrane, you should perform a vaginal examination to exclude the possibility of the cord prolapse. And again after at an interval of 2 to 4 hours, you can do the vaginal examination. And in the case of MENTO posterior, if the head remains high, that is in spite of good uterine contractions also, if the head is remaining high, that is if the head is not getting engaged, you can go for the cesarean section. Now let us see the indications of the cesarean section in the case of phase presentation. If there is a contracted pelvis is there, if the baby is big, if associated complicating factors are there, in those cases you can go for the cesarean section. Next is birth of the head. When phase appears at the vulva, extension must be maintained by holding back the synciput and permitting the mentum to escape under the symphysis pubis before the occipital diameter is allowed to sweep the perineum. In this way, the submentovertical diameter 11.5 cm can be distended instead of the mentovertical 13.5 cm into the vagina. And an elective episiotomy also should be performed if it is not performed properly. That is, during the birth of the head, you should hold the synciput in order to reduce the presenting diameter. And if the head does not descend in the second stage, a forceps delivery can be preferred and rotational forceps can be used. And when rotation is incomplete or position remains MENTO posterior, you can use the rotational forceps in case if the rotation is not occurring. Cesarean section will be necessary if the head has become impacted and there is any suspicion of disproportion. That is, during the process of labor, if there is no progress and if you are suspecting the arrest of labor or if you are suspecting the cephalopelvic disproportion, in that cases also you can go for the cesarean. Next, we can go to the brow presentation. If the fetal head is not fully flexed and not fully extended, in that case, brow presentation will be there. And brow means it is the portion between the anterior fontanelle and the orbital ridges. And if that portion is coming in at the brim of the pelvis, we are calling it as brow presentation. And the incidence of brow presentation is 1 in 1000 births. Next, let us see how to diagnose the brow presentation. The cephalic prominence and the groove between it and the back is less prominent. The head feels big and not engaged. On vaginal examination, you can feel the anterior fontanelle on one side of the pelvis and the orbital ridges and possibly the root of the nose at the other side. That is, both anterior fontanelle and the orbital ridges you will be able to see on either side. And for the confirmation, you can go for the sonography or radiography. Next is mechanism of labor in the case of brow presentation. The diameter of engagement is through the oblique diameter and the engaging diameter is mentovertical 13.5 cm. So there is no mechanism for the brow presentation in an average size baby. But if the baby is very small and if the pelvis is very spacious and if uterine contractions are effective, good uterine contractions are there, and if there is no other complications, you can try for the normal delivery. And usually in the normal cases there is no mechanism, and even for the posterior brow presentation also there is no mechanism. And cause and prognosis of brow presentation. There is a chance for obstructed labor in the case of persistent brow presentation. There is a chance for rupture of the uterus, and there is a chance for spontaneous. Sometimes if the head is getting flexed, that may leads to the vertex presentation, and if the head is getting extended, that may leads to the face presentation. In that cases, if the head is coming back to the face presentation, or if the head is getting well flexed, and if it is going to the vertex presentation, you can try for the normal delivery. Usually if the same raw presentation is coming, normal delivery will not occur. There is a chance for obstructed labor. And if there is no evidence of fetal compromise, labor is allowed to continue for a short, while in the case of further extension of the head converts, sometimes if it already I have told you, if you are suspecting that it may get converted into face presentation, or if there is a chance for getting converted into vertex presentation, you can wait. If the head fails to descend and brow presentation is persisting, in that case you should go for the cesarean section. And you can try for the manual correction of the face with full dilatation of this. If the cervix is fully dilated and if there is no other complications, you can go for the manual correction to the face presentation. And if the labor become obstructed and if the baby is died, you can go for the craniotomy for expelling the baby out. Thank you for watching this video. Thank you.